Thank you, Dr. Varshini. We are running a little short of time, so I'm going to skip the clinical approach because most of what I had to say has already been covered. This is what Dr. Ganga Prasad was telling you about optic atrophy being classified as primary optic atrophy, secondary when we see this kind of a picture with the gliosis surrounding the optic nerve, consecutive optic atrophy, and the etiological classification. Just to stress before we go ahead with the cases, history is extremely important, and especially a detailed history about the visual complaint, the onset, progression, whether there was partial recovery or not, whether it's gradual, painless, painful, trauma, everything becomes extremely important. The examination again has been extensively covered. So I'm skipping most of this here. Yeah, this is one more small point which I just wanted to make, which I'm not sure if anyone else has covered, is we do tend to underestimate optic atrophy in eyes with dense cataract and overestimate them in pseudophakic cases. So when you have somebody with, a pseudophakic in one eye and an NS3 in the other eye, just exercise a little bit of caution before branding it as optic atrophy. And investigations like we've covered should be tailored based on the history and the examination findings instead of just a large list that we could go ahead with. So in the end, the decision-making process would really be a step-ladder approach with the age, the symptoms, the vision, the kind of optic atrophy, and the findings. We'll move on to the cases in interest of time. So let me start with the first case. So this is a 64-year-old gentleman who came to us with history of decreased vision in the left eye since childhood, possibly after some injury, not very clear history, and then gave history of sudden decrease of vision in the right eye a few months ago, wasn't exactly sure, and which has been stationary since then. It did not recover. No pain, no known systemic illnesses. He had been evaluated elsewhere. A CT brain had been done and was normal. The visual acuity in the right eye was 20/50 and 6, left eye was 20/100 and 12. There was a right relative afferent pupillary defect. He was largely orthotropic, motility anterior segment was full. So now let's examine the disc, and like we were going over everything that has been covered so far, if you really had to look at this disc, what's the first striking feature? Does anyone want to volunteer? Right, so it's not completely pale. This is an obvious segmental pallor which is even more evident on the red free. The inferior half of the disc here is largely okay. This is the superior half that's pale. And this is the other disc. So this is again what we were talking about, how it's important to examine the other eye. So you can see this is a small disc with no cup. So this is classically what's described as the disc at risk. So we move on from here. This is the left eye. Yeah, this is just his previous history. There was a small macular scar, probably some old trauma in the left eye. And these are his visual fields. So this is the right eye. We can see the inferior altitudinal defect which corresponds to the superior area of pallor. So the diagnosis was non-arthritic anterior ischemic optic neuropathy. Now the diagnostic clues here, just to go over, was one, the age. Second was the sudden painless loss of vision. The segmental disc pallor. The other eye having a small disc with no cup. So all of these are features wherein there wasn't even any need for the imaging. Of course we had the normal imaging, but there wasn't a need for it. All of this, if it's there, it's fine, you can brand it as NAION. Now what about this last one here, no systemic illnesses? So we've been finding largely that even if diabetes and hypertension are common culprits, are not pertinent in the case, a large number of cases, especially in the Indian scenario, seem to be having hyperhomocystinemia, isolated, or even dyslipidemia, which is responsible for the ischemic optic neuropathy. So take home points: segmental pallor, sudden painless vision loss, and a small disc with no cup in the other eye. Now this is a second case. This is a 47-year-old lady. Complaints of blurring of vision in the left eye for 2 to 3 months. Again, no pain, no trauma. No other relevant history. Visual acuity 20/20 and 6 in the right eye, 20/30 and 6 in the other eye. Left eye had a relative afferent pupillary defect. Rest of the examination was largely normal. This is the right disc. This is where the patient has no complaints at all. This is 20/20 and 6. So appears cursorily normal. If you look at it a little bit, that area there is suspicious. So let's blow it up. This here is very typically what is an optic disc drusen. So we can see the excrescence here, and the rest of the disc is fairly okay. There's no cup, there's a peripapillary atrophy. All of this is very typical of discs with optic disc drusen. Now we move on to the other eye. This is her left eye. This is where she's complaining of vision loss. So it is a pale disc definitely, with a little bit of arterial attenuation surrounding the optic disc. This is the autofluorescence picture. Now this is very typical of optic disc drusen. You can see the drusen not only in the right eye where it was clinically evident, but in the left eye as well here. So this is her visual field. This is the right visual field. This is extensive loss. This is the left visual field with a small area here of field loss, which is probably explained by the drusen. Drusen are known to cause visual field defects. So this was a bilateral optic disc drusen with a left eye optic atrophy, probably secondary to NAION because of an optic disc drusen. Now just to explain here, optic disc drusen have been known to increase the risk of an ischemic optic neuropathy. The mechanism is supposedly that they contribute to the already crowded disc by further increasing the vascular crowding there. These patients may be younger than the other sort of garden variety of NAION that we see. The vascular risk factors may be present in only about 50%. So half of these patients you may never really find a vascular risk factor. And they may report transient visual loss, small episodes of visual loss lasting a few seconds prior to this onset. So this would all be giving us a clue here. Now the third case in this current series, this would be a 44-year-old male. Again, sudden painless blurring of vision in the right eye for the last 20 days. No known vascular risk factors, at least as per history. Vision 20/125 N36 in the right eye, 20/30 N6 in the left eye. Both the pupils sluggishly reacting to light. Rest of the examination normal. This is his fundus. Now this is the right eye. We can see here there is definitive disc edema. There are also a few hemorrhages, peripapillary here, and a few telangiectatic vessels. This is the left eye. This definitely has pallor, more temporal. So provisional diagnosis here in this case was because of this kind of appearance of the atrophy, of the edema in one eye and the optic atrophy in the other eye. This is what Dr. Ganga Prasad was referring to. We thought this was probably NAION in one eye and the other eye had an old NAION, now pale. So this is what is called Pseudo Foster Kennedy syndrome. Now this was his visual field. So you can see the inferior altitudinals in both the eyes here. So what do we learn here? Just the points from this case that I want to say: always examine both the eyes. The disc appearance can give a lot of clues. HVF can have a lot of supportive evidence and can actually eliminate the need for further investigations. Now, pseudo Foster Kennedy, when you see this kind of a disc edema in one eye, atrophy in the other eye, you always worry about true Foster Kennedy, where it's a compressive, usually described with frontal lobe tumors. So the clue here is that in pseudo Foster Kennedy, the eye with the disc edema, that's the eye which has had the ischemic optic neuropathy, is going to have poor vision. As versus true Foster Kennedy, the eye with the disc edema is because of papilledema. So unless it's extremely long-standing, it's usually likely to have good vision. So that would help you to rule out between the two. So before I move on to the next, I think we'll have Vivek present a series of cases, and then we'll come back to the next series.